Good morning to all. Today we are dealing with the third part of mucogingival problems. So there is gingival augmentation, coronal to recession, otherwise root coverage procedures. Okay. So understanding different stages and conditions of gingival recession is necessary for the prediction of root coverage procedure. So what is gingival recession? So you already know that is the exposure of root surface by an apical shift in the position of the gingiva. So while seeing this picture, you can know that there are different types of positions. There is different types of recession. So under recession, there can be apparent, there can be actual, and there is hidden type, there is visible type. So what is visible type? As the name indicates, what you are seeing. There is the amount of recessed area. Okay, and the hidden, that is coming under the gingival margin. So that will be the gingival margin to the base of the pocket. Okay, so like that, there is apparent and actual position. Actual position will be that is from the actual recession amount or actual attachment loss. That will be from the CJ. So from the CJ and to the base of the pocket. So this will be the addition of the visible plus hidden. That will be the actual. Apparent will be there is what from gingival level of the crust of the gingival margin. Okay, there is from apparent to the base of the pocket. Okay, so actual position is the level of the coronal end of the epithelial attachment on teeth, and apparent is only the level of gingival margin, what you are seeing here. Okay, so that is the apparent. So severity of recession is determined by the actual position of the gingiva and not its apparent position. Okay, so that is what we are seeing here. So the severity will be determined by the actual position, not the apparent position. Okay, so that is gingiva recession. And the predictability of the root coverage can be enhanced or by the different classifications. So we have got several classifications for it. There is in 1960, Sullivan and Atkins classified gingival recession as four anatomic categories. There is shallow, narrow, shallow wide, deep narrow, and deep wide. So this is the early classification. Okay, this helped to categorize the lesion but did not enable the clinician to predict the outcome of therapy. So the predictability of root coverage can be enhanced by the reasoned the other classification that is given by Miller. He classified the recession with regard to its breadth and depth in relation to gingival margin and remaining attached gingiva. Okay. He also described the loss of papilla. There is the interdental tissues. So he involved all the gingival margin, attached gingiva, and the interdental tissues. So how it has been classified? The first one is class 1. What is class 1? There is a marginal tissue recession does not extend beyond the mucogingival junction with no loss of interproximal tissue. So here we can expect 100% root coverage. What is class 2? There is a marginal tissue recession that extends to or beyond the mucogingival junction with no loss of interproximal tissue. So here also you can expect 100% root coverage. Whereas class 3, what is class 3? It will be extend to or beyond the mucogingival junction. There will be loss of interproximal tissue or tooth rotation. The interproximal bone is still coronal to the apical extent of the recession. Only 70% root coverage only we can expect here. Okay, whereas class 4 marginal tissue recession extends to or past the mucogingival junction with severe loss of interproximal tissue or tooth rotation. So here less than 50% root coverage is expected. Okay. So coming to the details of each one, there is class 1 as we told. You can see that it can be localized or generalized or it can be narrow or wide. You can see that there will be not be any loss of bone or soft tissue in the dental area. You can see that there is intact in the dental area, but it will not extend to the mucogingival junction. This is the mucogingival line, so it will not extend to mucogingival junction. The next one, there is a marginal tissue recession extends to or beyond the mucogingival junction. You can see that there is also no loss or bone of soft tissue area, loss of soft tissue or hard tissue in the dental area. This type of recession can be classified into subdivided into wide and narrow. Okay, so this is extending beyond the mucogingival junction. See, you can see that this is the mucogingival junction. There is this line. that is demarcates attached gingiva with the alveolar mucosa and it is extending, but there is no loss of interdental tissue. Whereas class 3, you can see that slight rotation can be there, cannot be there, but it will extend to beyond mucogingival junction and there is some amount of so soft tissue and bone loss. Okay, but still it is coronal to the level of recession. Okay. And class 4, you can see that interdental area will go beyond it. That is, it will extend to mucogingival junction and there is severe amount of soft tissue and bone loss. You can see clinically also. So then comes the recent classification, 2017 classification. They modified and they have made into recession type 1, that is RT type 1, RT type 2, RT type 3. So in clinically we are following this type, for clinical findings we are writing 2017 classification for gingival recession, and for outcome of the therapy, for planning the treatment, we are using Miller's classification. Okay, what is recession type 1? That is, they have included interproximal. Mainly they have taken the interproximal area. So that is gingival recession with no loss of interproximal attachment. So there is interproximal CJ is clinically not detectable at both mesial and distal aspects. You can see that both distal and mesial aspects, it is not detectable. That is interproximal CJ is not detectable. So that is class 1, RT type 1. Whereas what is RT type 2, there is some loss of interproximal attachment, but still it is not reached till the buccal attachment loss. So there is, it's still coronal to the buccal attachment loss. Okay, that is recession type 2. And what is recession type 3? That is a gingival recession associated with the loss of interproximal attachment. There will be loss, but it is greater than the buccal attachment loss. Okay, you can see that, see, it is coming apical to the buccal attachment loss. So that is a 2017 classification. So coming to the etiological factors for gingival recession, so it can be classified into predisposing factors and precipitating factors. So always the gingival margin, so discrepancies always follow the position of the teeth in the arch, root bone angle and mesiodistal curvature of the tooth surfaces. So what are the factors that is responsible for it or predisposing it? That is, bone dehiscence can be, that is according to the thickness of the bone, whether it's placed, excessive proclination of incisors and expansion of the arch. These are associated with greater risk of gingival recession. So that can be one of the reason, and tooth malposition as we told before, thin tissue can be one of the reason, inadequate keratinized gingiva or attached mucosa, and also frenum pull. So what are the precipitating factors that is leading to gingival recession? They are traumatic forces, there is aggressive toothbrushing, habits or choices such as smoking or oral piercing, and then wasting diseases like ablation. Uh, there is a friction from soft tissues. Ablation can be, abfraction can be, okay. So erosion can be, abrasion can be. So all things can lead to this recession, and plaque-induced inflammation, obviously, and orthodontic treatment, subgingival restorations, and similar therapies. So coming to the consequences of there is gingival recession. There is, it can lead to acidic problems, plaque retention, hypersensitivity, root caries, hyperemia of the pulp. So there is a need of root coverage procedure. So what are the treatment options for gingival recession? There is restoration in the non-surgical method. We have restorations, crowns and veneers. The crowns may be placed to widen the clinical crown, which may camouflage the exposed root surfaces. Construction of gingival mask. There is a silicone flexible gingival veneer or mask can be used. Then surgical root coverage techniques can be used. So what is predictability? There is root coverage predictability. So how it can get influenced? So mainly it is influenced by the mucogingival junction and the loss of interdental septa or interdental gingiva and the extent of malposition. These are the three factors which determines the success of root coverage procedures. Okay, mucogingival junction, there is adequate attached gingiva, how it is, then only they can go for the surgical procedures from the perical type of graft. Or what about the interdental septa or interdental gingiva? That is, if there is interdental bone loss, then it makes more complicated. And also the extent of malposition, if it is too much crowded, labily placed, Then there is if thin bond, thin tissue, that will also this affects the treatment. So, what are the criteria for the selection of techniques? Obviously, the surgical site should be free of plaque and inflammation, adequate blood supply to the donor tissue, anatomy of the recipient and the donor site, important, and stability of the grafted tissue to the donor site, minimal trauma to the surgical site. So, what are the root coverage procedures? We have free gingival autograft. So, we already explained the mucogingival problems first part and second part, and free connective tissue autograft is there. Pedicle autografts is there. So, there is an attached one, not free one. And under that, we have laterally positioned one or a double papilla flap, coronally positioned flap, and we have semilunar pedicle flap. Okay, other than that, we have subepithelial connective tissue graft, guided tissue regeneration, there is GCR membrane, and pouch and tunnel technique, and alloda. So, coming to the details of each procedure. Okay, so what is a graft? That you already know, there is a piece of living tissue that is transplanted surgically. So, what is the donor site? The area which donates the graft, either free or pedicle examined palate or adjacent to the defect area. Recipient side, there is area of defect which is prepared well before to receive the graft from the donor site. Okay. So what is free gingival autograft? So that is introduced by John in 1963 and the Sullivan Atkins in 1968. Simple and highly predictable when used to increase the amount of attached gingiva. Okay. It can also be used over an extraction socket or a Swiss graft. So Miller applied this classic free autogingival autograft with modifications for root coverage. So how it is done? The same way, so before that, if we are using for root coverage procedures, right? So that is we have to, roots are planed and varnished and then it will be applied. The acetic acid will be applied for 5 minutes for root conditioning. Then we have to prepare the recipient site. How we can prepare the recipient site? So always we have to prepare a firm connective tissue bed to receive the graft. Okay. So that is this is very necessary that we have to, in free grafts, the recipient bed surrounding the denuded root surface should be extended wider to allow for better blood supply. Okay, it has to be widened. This is necessary because a portion of donor tissue overlies over the root surface, so this does not have blood supply. So we have to have a wider area adjacent to the root surface. Okay, so make a horizontal incision in the interdental papilla at the right angles. You can see that it should be at right angles. Okay, to create a margin against the graft which may have a butt joint with the incision. Then we have to make vertical incisions. They are made at proximal 9 angles of the adjacent tooth and the retracted tissue to be removed. It has to be removed. Okay. Then made an intact periosteum in the apical area. So then coming to obtain the graft from the donor site. So here there is a free gingival autograft, that is we are obtaining from the donor site. That is the usual donor site, that is the palate. So you can see the template is being placed on the palate. A shallow incision is made to the desired thickness and one edge of the graft. Elevate the edge and hold it with tissue forceps or with the suturing. Continue to separate the graft with the blade. Then the graft is removed and the palate is sutured for hemostasis. So this is what we are doing. That is the whole procedures in this diagrammatic representation. You can see that we are taking the epithelium and connective tissue. There is a free gingival graft and we are keeping it. So that is transferring it to the area and then stabilizing it with the sutures. Okay. So then we have given periopack for the donor site. So this is the healing of the recipient. So this is what in the clinical diagram you can see that there is recession. See, we have prepared the connective tissue bed. We have denuded the root surface around this and we have made a wider area for the placement of the graft. You can see that this has been placed and then the sutures have been placed to secure it. Okay, the suspension suture and the periodontal suture has been given and then this is the post-operative view. Okay. So then coming to the free connective tissue autograft. So this is introduced by Levine in 1991. So this is same as that of the free gingival autograft. The only thing is that here we are taking only the connective tissue. There is the only difference with this. Okay. So this is following is a step-by-step procedure that is already we have explained in the previous lectures. That is divergent vertical incisions should be given at line angles of the two to be covered, creating a partial thickness flap for at least 5 mm apical to the receded area. So then we have to apically pull it and suture to the periosteum using a gut suture. Then we have to, the same way how we have done for free gingival autograft, we have to thoroughly scale and root plane the exposed surface. The facial prominence on the root surface is also reduced, which is a favorable anatomy onto the donor tissue is placed. You can see that obtaining the graft from the palate. So there is a connective tissue graft. So it is sutured after the graft. The donor site is sutured after the graft is removed. You can see that the transferring the graft to the recipient side and suture it with the gut suture. Good stability of the graft must be obtained with a minimal number of sutures. Then we are covering the graft with sterile foil and placing the periodontal pack. So coming to the another technique, that is a pedicle autograft, which is very important. That is very important for your exam point of view. That is a pedicle autograph, that is the taken attached type of autograph taken from the adjacent area. Okay, so we have several type of techniques. So first one, that is a horizontally displaced flap and laterally displaced. That is laterally we are displacing from the adjacent area. Okay. So this has been described by Group and Warren in 1956, that is used to cover isolated denuded root surfaces that have adequate donor tissue. Only if there is adequate amount of tissue adjacent to the recipient area, only we can go for this pedicle type of autographs. Okay. So adequate vestibular depth also necessary. Adequate attached gingiva and adequate vestibular width. Everything if it is necessary, you can go for lateral displacement. So we are going to these step-by-step procedures. The first one, that is the prepare the recipient site. So this the same way root surface has to be thoroughly scaled and root planed. Then the epithelium will be removed around the denuded root surfaces. The exposed connective tissue will be the recipient side for the laterally displaced flap. So we will be removing just the epithelium. The connective tissue bed will be the area to receive the lateral displaced flap. Okay. So then prepare the donor site. So you can see that we have to prepare the donor site. So how we can prepare? We can make a vertical incision from the gingival margin to outline the flap adjacent to the recipient side. You can see that this has been denuded, and you can make a wider area involving the papillary area also. Then you can make the vertical incision. Okay. So that is what here, that is a preparing the donor side. We are taking the maximum widen area. So the release incision will be given. So it can be of different types. It can be of this type, it can be widened, it can be converged, and then the oblique incision. It can straight like this. So different techniques are there for obtaining the donor site. Okay. So then we will be making a wider area of base, and then we will be transferring the flap. We will be sliding the flap laterally to the adjacent root and fixed with interrupted sutures. Okay, then we will protect the flap and donor side with aluminum foil and a soft periodontal pack. Okay, always the periodontal tissue of the donor side should have a satisfactory width of attaching wire without dehiscence or fenestration in the bone. So that is more important. So it can be a full thickness or partial thickness flap may be used, but the lateral one is preferable. Always you can see that all like partial thickness is more advantageous. Otherwise it will be leading to like a risk of loss of facial bone in relation to the donor side. So we will avoid that. So always we will prefer for partial thickness flap. Okay. So then coming to the next, there is, you can see the clinical picture how it is done. You can see that the epithelium has been excised. You can see that the scaled and root plane and epithelium has been excised, and we are preparing the connective tissue bed. And then we are making the incisions here involving the papilla also, and then we are transferring. transferring to the other area. You can see that here it is. This the its epithelium and conti tissue has been transferred to the other area. So it should be placed flat and be firm without excess tension on the base. So that is why we are making a releasing incision. There should not be any tension here. Okay. Then this suspensory suture, we will be giving interrupted sutures, and also suspensory suture may be used around the involved to prevent the flap from slipping the bike away. Okay. So there are different variant techniques for making the incision, as we told before with the schematic diagrams. Okay, you can see that the oblique vertical incision or oblique incision will be given distal to the adjacent side. Okay, so this is the healing period. You can see that this is the healing period, and here also epithelium has been formed, and here also healing has been done. So coming to the indications, contraindications, advantages and disadvantages. So what are the indications? You know that sufficient width, length and thickness of keratinized tissue should exist adjacent to the area of gingival recession. You can go for lateral pedicle. Coverage of the exposed root is limited to only 1 or 2 teeth. That is more important. Very isolated type of recession, isn't it? And then this method is more suitable for root coverage in gingival recession with a narrow mesiodistal dimension also. What are the contraindications? Insufficient width and thickness of keratinized tissue in the adjacent donor side, extremely thin bone in the donor side, or an osseous defect such as dehiscence or fenestration. Definitely you cannot go for lateral pedicle graft. Gingival recession are extremely protrusive. Deep periodontal pocket and remarkable loss of interdental alveolar bone in the adjacent area, narrow oral vestibule, multiple teeth involved. Then coming to advantages, one surgical area. Yes, definitely one surgical area. Blood supply of the pedicle flap is covering the root surface is preserved. Postoperative color is harmony with the surrounding tissue. Disadvantages applicable for relatively minor gingival recession. That is what it is limited to only 1 or 2 teeth, and success rate is not high. Okay. So we have another variant of pedicle flap, that is double papilla flap. So double papilla flap attempts to cover roots that is renewed by isolated gingival defects with a flap formed by joining the contiguous halves of the adjacent internal papilla. So you can see that if there is, that is, we are not taking from one side, we are taking from both sides, both adjacent, from mesial and distal. So the advantage is that if you are having there is less amount of tissue from one side, you can make use of from both sides. Okay, but disadvantage is that you can see that the interdental area, the blood supply will be hampered, isn't it? The advantage is that we will be getting tissues from both sides if there is not enough adequate attached gingiva on one side of the adjacent area. You can take from both sides. Okay, so that is if sufficient width of attached gingiva is there is the step one is two vertical incision extending beyond mucogingival junction. So there is a first step. You have to make two vertical incisions extending beyond mucogingival junction. Then you can make there should be trapezoid type. It should be oblique incisions. Okay, two vertical incisions should be oblique to the line angles. Then we have to have a crevicular incision, raise the mucoperiosteal flap. Then we have to have the scaling and thorough scaling and root planing of the surface. Place the flap coronal to the treatment level. So we have to place the flap coronal. Then we are sliding up towards the coronal area. You can see that, see, it is coronally displacing and it is covering here. So there should not be any tension. So you can have a releasing incision here, and both sides you can give a releasing incision, so oblique incision. Then suture it to the sides and the interdental area. Then you have to give periodontal dressing, and this is the post healing site. Okay. So if there is insufficient width of attached gingiva, what we can do? We have to have two stages. So we have to create first the width of attached gingiva, and then only you can go for it. Okay. So that is, we have to have free gingival autograft to increase the width of attached gingiva. So this creates several millimeters of granite attached gingiva apical to the denuded root. Then after 2 months later, you can go for the second stage operation will be performed to coronally reposition the flap. Okay. So always you have to think that the same procedure, vertical incision should be given, and it should be, then we have to make a bed for it. That is, internal bevel incision should be made from gingival margin to the bottom of the pocket to eliminate the disease pocket. If there is any pocket depth, you have to eliminate that pocket there, and then you have to coronally displace it. Okay, so that is coronally displaced. Then coming to the next technique, there is the next variant, there is the semi-lunar flap. That is by Tarnow has described semi-lunar coronally position flap. This is a very simple procedure, but this can be only indicated in recession of less than 3 mm of the facial gingival biotype is thick. So if there is minimal amount of recession, and if the facial gingival biotype is thick, then you can go for it. Okay, so how it is done? So here you can see that there is a mild amount of recession. You can see that the gingiva is also available. So this is a mild recession. You can go for a semi-lunar incision. There is a semi-lunar incision will be given which follows the curvature of the gingival margin, ending 2 to 3 mm short at one tip of the tip of the interdental papilla. You can see the next picture. See, this is a semi-lunar incision. This will be 2 to 3 mm away from the interdental papilla. Okay. Then we have to make the clavicular incision to made to split the incision. Okay. This has to split the incision, and then the tissue will collapse coronally, covering the denuded root. So this you have to push it down coronally, and hold the tissue is moist goes for few minutes. You can see that. See. This technique is very simple and predictably provides 2 to 3 mm of root coverage. So it can be performed several adjoining teeth. Okay, if it is the same case for multiple teeth, you can do for all the teeth together. So the technique is indicated for areas the recession is not extensive than 3 mm, and the facial gingival biotype should be thick. So mainly it is successful for maxillary anterior region. Okay. So that will be more advantages for anti-region. So this is semilunar. So what are the advantages of it? No tension on coronal migration of the semilunar flap, no narrowing of the oral vestibule, good aesthetics you can always achieve because it is the height of internal papilla is preserved, because no incision is made to the internal areas also, flap suture and periodontal dressing not necessary. Okay, that is also more comfortable, right? And simple surgical procedure and minimal surgical time, minimal post-operative discomfort, applicable to minimal gingival recession across multiple teeth. Disadvantages are not applicable in cases of extreme gingival recession. Thick keratinized gingiva necessary for adequate thickness of creating partial thickness flap. Where an osseous dehiscence or a fenestration exists apical gingival recession area, you cannot go for it, isn't it? What are the indications? That is maxillary anterior teeth and premolars with 2 to 3 mm recession can be done as a complementary procedure for small areas of recession, remaining after other procedures for root coverage. It is applicable especially in cases where free autogenous gingival grafts or continuous tissue grafts are performed because thick keratinized gingiva can be used. Okay. So coming to the subepithelial continuous tissue graft. So out of this is very important. This can be asked as a separate question. That is subepithelial continuous tissue graft. So this is described by Langer in 1985. This is indicated for larger and multiple defects with good vestibular depth and gingival thickness to allow a slit thickness to be elevated. Okay, so here we should have adequate thickness of attached gingiva and also vestibular depth. Why we should need to do split thickness flap. Okay, the donor continuous tissue is sandwiched between the split flap. So we will move into the procedures. The first procedure is step 1, that is raise a partial thickness flap with a horizontal incision 2 mm away from the tip of papilla and 2 vertical incisions 1 to mm away from the gingival margin of the adjoining teeth. So you can see that See, you can see that this is the area where we have to do the partial thickness flap. You can see that. Okay. So this is the recession area. So we are not involving the interdental area. So we will be removing the tissue without disturbing the interdental area. So this is a horizontal incision we are making 2 mm away from the tip of papilla, and two vertical incisions of 1 to 2 mm wide are made from the gingival margin of the adjacent tooth. Okay. So this incision should extend at least one tooth wider mesiodistally, okay, than the area of gingival recession. So extend the flap to mucogingival fold. We have to extend it. Okay. So the next one is the exposed root surface will be scaled and root planed. So then we have to, so we have prepared the conti tissue bed and obtain a subepithelial conti tissue from palate near the molar. So we have to get the subepithelial conti tissue graft from the palate, that is by means of horizontal incision. So 5 to 6 mm from the gingival margin of molars and premolars. The palatal wound is sutured in a primary closure. Then place the conti tissue on the denuded root. Okay, that is where conti tissue is sandwiched in the split flap and then sutured with resolvable sutures to the periosteum. Then cover the graft with the outer portion of split thickness flap and suture it interdentally. Okay, cover the area with the dry foil and surgical dressing will be given. So after 7 days, the dressing and sutures will be removed. Okay. So that is the subepithelial conti tissue graft, and we have a subperical conti tissue graft also. That is only with conti tissue graft will be taken from the adjacent area. Okay, that is one of the variant of. So you can see that this is subepithelial conti tissue graft being taken from the palate and then placed on the area, and then we are placing the epithelium over it and then suturing. Okay. So coming to the guided tissue regeneration for root coverage. So Pini Prato et al. Describe a technique based on the principle of guided tissue regeneration. So what is this? It should result in reconstruction of the attachment apparatus along with the coverage of the denuded root surface. Okay. So we are moving to the step-by-step techniques. That is, a full thickness flap is reflected to the mucogingival junction, continuing as a partial thickness flap 8 mm apical to the mucogingival junction. So first, from the initial area, we will be incising the, or we will be making a full thickness flap first thing, then continuing as a partial thickness flap 8 mm apical to the mucogingival junction. Then after that, to the mucogingival junction, we will be going with a partial thickness flap. Okay. Then the membrane will be placed. This membrane is placed over the denuded root surface. So it will be trimmed and adapted to the root surface and covers at least 2 mm of the marginal periosteum. It will be kept on this. And then a suture is passed through the portion of the membrane and that will cover the bone. So this suture is tied. So the suture is tied on the exterior end to bend the membrane and creating a space between the root and membrane. So this space allows the growth of tissue beneath the membrane. Okay. The flap is then positioned coronally and sutured. Okay. So after 4 weeks later a small envelope flap is performed and the membrane is carefully removed. So nowadays we are using a resorbable type of GTR membrane. So then we will be placing again, the flap will be placed coronally if it is unresorbable to protect the growing tissue and suture. Okay. So then 1 week later the sutures will be removed again. So that is about the GTR membrane. Okay. So GTR technique is better when the recession is greater than like for its advanced level of recession you can go for GTR. So then coming to the pouch and tunnel technique. What is pouch and tunnel technique? As the name indicates, it is something like making a pocket inside and making a tunneling method, right? So it is also referred to as a coronally advanced tunnel technique also. So main advantages is to minimize incisions. So provide abundant supply to the donor side. Pouch allows intimate contact of donor tissue to the recipient side. Aesthetic improvement, good results with maxillary anterior with sufficient vestibular depth. So this technique is especially effective for the anterior maxillary area in which vestibular depth is adequate and there is a good gingival thickness. So coming to the steps, the first one is circular incision will be made around the incision. So we will be making a circular incision. You can see that we will be making a pouch inside. Okay, using the curator blade, a tunnel is being created beneath the adjacent papilla. Okay, so you can see that, see this area and to the adjacent area. So without incising the incisive papilla, you will be making a tunnel inside it. Okay, inside the buccal papilla. Then the split thickness pouch is being created apical to the papilla which has been tunneled. You can see that, see, this has been passed. The probe is easily passing through it, so that is getting tunneled. So conduit tissue derived from the palate. So we will be deriving the conduit tissue from the palate and this will be placed inside the pouch through sutures. So with the sutures it will be inserted inside. Okay, with a portion of covering the denuded surface, then we suture the flap by placing it more coronally. Okay, you can see that this is the deriving conduit tissue we are placing inside, then we are pulling down and then suturing it. So this is the post-operative view. Okay. So this method you can use it. Allodum also can be placed for this soft tissue grafting for this pouch and tunnel. So what are the indications? Soft tissue augmentation, multiple adjacent gingival recessions, lack of graftable parietal tissue, patient reluctant to have a second surgical site, correction of gingival or mucosal amalgam tattoos. We can go for allodum placement. For tissue augmentation, you can see that allodum, the same way how we are creating pouch and tunnel technique for conti tissue, we are placing the allodum instead of conti tissue. That's it. So then periodontal dressing will be given. So coming to the conditions necessary for successful root coverage. So appropriate case selection is very important. There should not be no loss of an dental papilla and dental alveolar bone adjacent to the gingival recession. So if there is bone loss, there is not only, so we have to go for the flap technique, not the root coverage procedure alone will not help to correct it. Okay. So sufficient internal papilla should be there adjacent to the gingival recession area. Sufficient blood supply ensured. Root surface covered with thick donor tissue. Donor tissue adapted closely to the recipient sites and suture. Dead space between the donor site and tissue and the recipient site will interfere with circulation. No severe decay or abrasion on exposed root. What are the criteria for selecting the procedure? Recipient site. Whether gingival recession is limited to one tooth or extends to multiple teeth. Degree of gingival recession, amount and thickness of existing keratinized gingiva in the area of recession. Relationship between the height of adjacent internal papilla and gingival recession. Whether the area of recession protrudes radially from the dental arch. The relationship between gingival recession area and the smile line. Whether restorative or post-orthodontic treatment after root coverage is necessary. Donor site. Whether the area adjacent to gingival recession can be used as a donor site. There is depending on the amount of keratinized gingiva, thickness of keratinized gingiva, size of adjacent dental papilla, thickness of the alveolar bone covering the donor tissue, thickness of palatal soft tissue used as donor tissue. So criteria for the successful root coverage. The gingival margin is on the CJ. In class 1, class 2 gingival recession, you can go for root coverage procedure, and if the depth of gingival sulcus is within 2 mm and there is no bleeding on probing, there is no inflammation, nothing, there is no hypersensitivity, color match with adjacent tissue is aesthetically harmonious. So these are the summary of all the techniques and you can go through it, the methods and its indications. Okay, this will help you to find out the technique, the appropriate technique for each case. Okay. So treatment options for various clinical conditions also being given here. Okay. So conclusion, various techniques are available for root coverage. Blood supply is the most significant concern behind all procedures. So newer techniques are constantly being developed and are being incorporated into periodontal practice. But careful analysis and selection of appropriate technique play a major part in the success of root coverage. Okay, then thank you. Have a nice day.